Hello, anatomy colleagues. This is Dr. Alsup, and let's begin our discussion of the muscles of the upper limb. So we're going to start with those muscles that actually have more proximal attachments on the axial skeleton, and then distal attachments either on the pectoral girdle or the humerus. And then we're going to end our discussion with the muscles of the shoulder region. So we have, as you can see here, a lot of muscles to get through. You can see in the learning objectives specifically what I want you to know about each one of those. So let's kind of just review again in terms of what we mean by axio-appendicular. And I have anterior here, but we'll actually discuss some of the posterior ones as well with the trapezius and the latissimus dorsi. So these muscles are going to move the pectoral girdle, and then in certain portions, particularly say like with the latissimus dorsi and the pectoralis major, this can actually move the shoulder joint as well. And so these bellies are going to be associated with the thorax, so either anteriorly or posteriorly. So their proximal attachment is on the axial skeleton, and then their distal attachments are either on the scapula or the humerus. So let's start with one of the big ones. So we're going to start with the anterior muscles of the axio-appendicular muscles, and then we'll talk about the posterior ones. So the prominent one when we're talking about the anterior is the pectoralis major. Generally, when you hear somebody referring to their pecs, this is what they are talking about, not the deeper pectoralis minor. And there are going to be two major heads or attachment sites in terms of the pectoralis major. You're going to have the clavicular, which will have its attachment on the clavicle. And then the sternocostal, so they're going to have their attachment sites on the sternum as well as the costal cartilages. And then they will coalesce, both these heads, the muscle bellies will kind of join together, and then the distal tendon will be shared between these two muscles. And that's going to be associated fairly close to that intertrabecular sulcus. Now, when both heads are contracting at the same time, this will cause the shoulder joint, because recall, it's crossing the humerus, so it's crossing the shoulder joint. This will cause adduction, so think adding back to the body, as well as medial rotation. If only the clavicular head is contracting, which is possible, so sometimes you can only have these muscle fibers right here contracting, this will cause flexion of the shoulder. And then the sternocostal head, if contracting by itself without the clavicular head also contracting, will cause extension of the shoulder joint from that flexed position. So you can see this is a fairly large muscle. It's fairly complex, having the various heads. And so you can see it's capable of a lot of the actions that are possible at the shoulder joint. Now, deep to the pectoralis major, so if we're looking at this cadaveric image here, here's the pectoralis major that's been reflected. And then deep to that, you will have the pectoralis minor. So anytime you have a major and a minor, the major means it's a larger size than the minor, as you might have guessed. And so this is also going to have its proximal attachment on the axial skeleton, specifically the ribs, and its distal attachment is going to be on the coracoid process of the scapula. So it is not crossing the shoulder joint. It does not have its distal attachment on the humerus, so it will not directly affect the actions of the glenohumeral joint, but indirectly it can. Now you'll see that pectoralis minor will play a role in terms of protraction of the scapula. I'll talk a little bit about what that is in a moment, but really the major action of pectoralis minor is to stabilize the scapula during other types of movements that can occur, particularly at that glenohumeral joint. Another muscle that doesn't get as much discussion, but it's actually a very powerful muscle, is the serratus anterior. And this is going to be kind of on the sides of the thorax. You can see here it's going to have its proximal attachments on many of the ribs. It's named due to its kind of serrated appearance, kind of the saw-like appearance. And its distal attachment is going to be on the medial border of the scapula. So again, not crossing the shoulder joint. And this is a very powerful protractor of the scapula. So think of the scapula moving forward. And that's where the serratus anterior is going to play its bigger role. Sometimes you can see these fairly hypertrophied. So if you can think of the types of actions or activities or exercises that would play a role there. Now, this muscle is unique in terms of its innervation. Well, other muscles are not really innervated by the long thoracic nerve. But one thing I want to note, and I haven't really talked about this very much, is that most of the nerves that are going to innervate a muscle are going to kind of be related to that muscle and kind of enter into the muscle region deep to the muscle. And that makes sense. It's going to be protected by the muscle. So if you have some type of piercing injury of a muscle, generally it's protected because that the nerve is going to be protected because it's deep to the muscle. This is not the case in terms of the long thoracic nerve. So you can see that this long thoracic nerve is kind of going and skirting along the superficial side of the muscle. And that's going to go kind of right along the lateral sides of the thorax region. And so that's really unique. It also makes it a little bit more susceptible to injury because of that more superficial position. And so injury to the long thoracic nerve may cause what's referred to as a winged scapula, but really what we're talking about here is paralysis of the serratus anterior. So what will happen is that medial border of the scapula, because you're not really capable of doing protraction to the strength that you would with serratus anterior working, that medial border is going to move posterior laterally, supposedly looking kind of like angel wings towards the back there, particularly when you have kind of your arms out in front. That will be really marked there. So if you think, say you had like a stabbing wound to the lateral side and knock out the long thoracic there because it's more superficial, that would cause this muscle to not work and protraction not really to be possible. So that's where the wing scapula comes from. All right, now we're moving to the posterior side. So those muscles that we talked about were more anteriorly placed or laterally placed when we're talking about the serratus anterior. Now we're talking about muscles that are predominantly posterior with two fairly large muscles. The more superior one is referred to as the trapezius muscle. All right, so your traps, that's what we're talking about here. And it's going to have a lot of more proximal attachments or origins. One of those is that external occipital protuberance, that bump on the back of the occipital bone, as well as many of the midline structures in this region. So think kind of spinous process region. And it will insert on the clavicle, as well as the acromion and spine of the scapula. So again, very firmly within the pectoral girdle region, not crossing over to the humerus. This muscle is innervated by the accessory nerve. And I want you to real quick think about another muscle that is innervated by the accessory nerve that we've talked about. That's right. I know you said sternocleidomastoid. Remember that rope-like muscle in the neck? So you have two major muscles innervated by the accessory nerve, trapezius and sternocleidomastoid. And remember, in our discussion of the sternocleidomastoid, we talked about how accessory is solely motor. So it only can have motor fibers associated with it. So in terms of the sensory or afferent fibers for the muscle, that is going to be related to C3 and C4. So fibers from the cervical spinal nerves 3 and 4. So unique, because usually when we say a nerve is innervating a muscle, it does both the motor portion as well as the sensory portion for like proprioception. Trapezius can do a lot, and it makes sense. It's a very, very large muscle. Its fibers are different depending on what level of the trapezius you're at. So trapezius can play a role in terms of elevating the scapula or depressing it. Retracting, so if you think about protraction is moving the scapula forward, retraction is kind of it moving back. Think of the shoulder blades, the medial portions of the scapula kind of coming closer together, as well as rotating the scapula superiorly. And you can see that kind of right here, particularly in terms of that glenoid fossa, allowing it to rotate superiorly, which will play a role in terms of allowing some of the actions that can occur at the shoulder joint. The other large muscle that's associated with the posterior back region is the latissimus dorsi, so the lats, if you hear that sometimes. So again, this is an axio-appendicular muscle, so its proximal attachment is going to be on the more axial skeleton portion. It's also in this region right here called the thoracolumbar aponeurosis. but you can see it's kind of skirting along right here. It even has a little bit of attachment on the hip bone, so it's a fairly expansive muscle. But also I want to note that distally, it does attach to the humerus. In fact, it's going to have its attachment on that floor of the intertrabecular sulcus that we talked about when we were talking about the humerus. So it crosses the shoulder joint, therefore it can affect the actions directly of the shoulder joint. And so two of its strongest actions are going to be extension of the shoulder joint as well as adduction. So if you think about swimming, that action of extension and adduction are fairly forceful in certain swim strokes. So sometimes you hear this muscle referred to as the swimmer's muscle. It also will play a role in terms of medial rotation of the joint, shoulder joint. Okay, now let's talk about some muscles that are intrinsic shoulder muscles. So they generally will have their muscle attachments. The more proximal attachment will be on the scapula and the more distal attachment on the humerus. So these tend to be shorter muscles than the muscles we just discussed. And as they cross here, they can directly affect the glenohumeral joint. And many of these, while they will have specific actions that they play a role in, they're really playing an important role in terms of maintaining the integrity of the shoulder joint. And the big one here is going to be the deltoid muscle. This is also the more superficial of them. I always think of it as kind of the cap on the shoulder. And it's divided into three parts. You're going to have the clavicular part, which makes sense. It's going to have an attachment on the clavicle. You'll have an acromial part, and you'll have a spinal part. And these all kind of come together to have an attachment on the shaft region of the humerus. Specifically, the attachment point is called the deltoid tuberosity, but I'm not going to have you memorize where that's exactly located. And these three heads, or these three parts, can act independently, but when they do act together, they are the most powerful. So deltoid is the most powerful abductor of the shoulder, so abducting away from the midline. So this is kind of the key action that occurs with the deltoid muscle. Depending on which fibers are contracting, it can also play a role in terms of flexion and extension, as well as medial and lateral rotation. So this is pretty much every muscle, or excuse me, every action that can occur at the shoulder joint except for adduction, because it's too busy abducting. So that's kind of the major role there. This muscle is going to be innervated by the axillary nerve, so one of the terminal branches of the brachial plexus. Remember, we talked about the axillary nerve kind of looping around that surgical neck of the humerus, which would be deep to the deltoid. All right, and then the rotator cuff muscles. So these are going to have their proximal attachment either on the posterior side, which is most of them, of the scapula, or the anterior side. So the three posterior rotator cuff muscles are the supraspinatus, so above the spine of the scapula, the infraspinatus, below the spine of the scapula, and the teres minor, which you can see here. You do have a teres major muscle that also is going to go and attach on the humerus. It is not considered a rotator cuff muscle, so it's not forming the rotator cuff around the shoulder joint. All of these muscles on the posterior side of the scapula that are part of the rotator cuff have their distal attachment on that greater tubercle, and you can see that kind of right here. And underneath here would be the head, would be the glenoid cavity and the head of the humerus, so you can see how it kind of just encloses that shoulder joint region. The supraspinatus muscle, the one that's above the spine, will initiate abduction of the shoulder. So I was just talking about how the deltoid muscle is the abductor of the shoulder, and it certainly is the most powerful one. But in order to get like the first 15 degrees of abduction of the shoulder joint, supraspinatus needs to play a role, because just based on how the deltoid is positioned, it can't really initiate that action very well. Sometimes gravity can allow that to happen if something happened to the supraspinatus, but it's really supraspinatus that is playing that role in initiating those first few degrees of abduction, and then deltoid takes over from there. The infraspinatus and the teres minor muscles will be the lateral rotators. Think the anterior side of the humerus is moving laterally. So these are going to be the major lateral rotators of the shoulder joint. And then the one anterior rotator cuff muscle is the subscapularis. You can see that here. You can see how its tendon is heading over towards the lesser tubercle, and it's kind of forming that anterior portion of the rotator cuff, the tendon will. So whereas the infraspinatus and the teres minor were lateral rotators, the subscapularis will be a powerful medial rotator of the shoulder joint. Now, you've likely heard of a rotator cuff injury. Either you've experienced one or you know an individual who has, and this can be so many different things. It can mean many, many different things. One of the more common is some form of a tear of a portion of that rotator cuff, so any of those tendons. It can be a full-on rupture, which is a bit more serious. And when you have these types of injuries, this can cause ever-increasing degrees of instability of that glenohumeral joint, because we talked about how important that rotator cuff is in terms of the stability of the shoulder joint. In terms of which tendons are the most common to be injured, it is the supraspinatus tendon. And that makes sense if you think about it. So remember that supraspinatus muscle is going to be located above the spine of the scapula. Its tendon has got to go to the greater tubercle, and it does so by kind of traveling through this bony tunnel right here between the coracoid and the acromioclavicular joint region. And so if you think of actions of like extensive abduction or circumduction, you can think about how that tendon may start getting pinched in that region. Or say you have the bursa in there becomes inflamed, and that can affect the tendon there as well. So by far the most commonly injured component of the rotator cuff is this supraspinatus tendon. All right, excellent. So I think that we're going to answer this question. It's a little tricky. Generally, I don't like to ask too tricky of a question, but so damage to the axillary nerve may affect all of the following actions except which of the following? Is it, and these are all of the shoulder joint. Is it abduction, adduction, extension, flexion, or medial rotation? So take a minute and think about it. First of all, you need to remember which muscle is innervated by the axillary nerve. And hopefully you're landing on the deltoid is innervated by the axillary nerve. There's other muscles as well, but the one that I want you to focus on is deltoid. And remember, we discussed that the deltoid can do a lot based on which fibers are contracting. Abduction is kind of the main action of the deltoid, or its most powerful. But it can play a role in terms of flexion and extension, so those aren't correct, as well as medial and lateral rotation, so E is not correct. So basically, it's capable of all the actions that can occur at a synovial joint other than adduction. So B is the correct answer. The deltoid is capable of all the following actions except for adduction. All right, excellent. So just a little tricky. I bet you felt good once you kind of thought through it there. So that is going to be those muscles associated with the shoulder as well as the axio-appendicular region. Now we're going to move on to the muscles of the arm and the forearm. So I'll see you in the next video. Please reach out if you have any questions. Thanks.